All right, so it's 9 o'clock. Let's make sure we have the recording on. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum, everyone. Welcome and thank you for joining the webinar today. Today we have the distinct pleasure of having a great speaker with us, Dr. Saad Usmani, who is well known in our circle, does not need any introduction, is the chief of the myeloma service at the Sloan Kettering. So without further delay, I'll let Dr. Usmani proceed with his talk. Thank you.
Thank you, Faiz Bhai. Assalamu alaikum, everyone. It's a pleasure to be here this morning. Let me share my slides and get started. Uh, this is a wonderful platform in which we've heard many talks over the past several months, including the topic of multiple myeloma. And for the purpose of this particular talk, I wanted to provide a more forward-thinking kind of a talk. And so some of the data that you may have seen in other talks would probably show up here as well, but I wanted to provide a context of where things are going. And I understand that we are going to have listeners from Pakistan, from other parts of the world, as well as trainees and doctors in the United States. And this talk may look like science fiction or very forward thinking for outside of the United States. But a big part of what I want to do is have this aspirational goal of actually sharing this way vision and direction so that we can actually do things in Pakistan. I think it's all achievable. So with that being said, these are my disclosures, and I want to, start with just a statement of the problem. Multiple myeloma is the second most common blood cancer that occurs worldwide after lymphomas. And believe it or not, it's more, common than ALL, than Hodgkin's. Almost 3 to 4 times more common than ALL or Hodgkin's. If you put them together along with, mantle cell or follicular, that's the incidence and prevalence of multiple myeloma in the world. So only diffuse large B cell is more common. So with that being said, myeloma is typically diagnosed in terms of presentation. We all know that patients can present with bone pain and lytic lesions. Anemia and renal failure ends up being a common feature. We used to see a lot more hypercalcemia when I was a trainee, but we are diagnosing patients a little early. We do see this in the relapse setting, but certainly, we do see hypercalcemia. And then there is a qualitative and quantitative decline in the immune function in myeloma patients. So recurrent bacterial infections can happen. In the United States, the incidence of all newly diagnosed patients, if there were 100 patients being diagnosed with cancers, 2 out of 100 are myeloma patients. The diagnosis is typically around the age of 70, occurs twice as more commonly in the Black population than the white population. Very interestingly, the Black population is probably 5, 6 years median age younger. So is the Asian population. And in fact, I see, being at Memorial Sloan Kettering, I see a lot of Pakistani and Indian patients being diagnosed here as well. And guess what? They're much younger than this stated age. So I think these are, important things. In terms of, what are the genetic alterations? It's more to do with, um, um, the racial and ethnic background. There are some late changes that can occur. I think the exposure and environment plays a much bigger role here than where you were born and where you came from. I think that's my feeling. But we are trying to prove and disprove all of those hypotheses. So this next slide talks about the diagnostic criteria. Myeloma begins with the precursor condition that we describe as monoclonal gammopathy of undetermined significance. And that is really based on disease burden and the M spike value and the fact that there are no SLIM or CRAB criteria. The SLIM criteria were developed in 2014 after almost 2 years of debate whether to include them or not, and looking at various data sets by the International Myeloma Working Group. Um, uh, um, and um, and then the smoldering criteria is again a disease burden dependent based on M spike in the number of plasma cells being 10% or more, but not more than 59%. And then myeloma, along with the slim graph criteria, there are some you know what we call markers of disease. So slim would be having 60% or more plasma cells in the bone marrow, the light chain ratio being 100 or more, and myeloma focal lesions. I'm going to actually stop sharing my slide. For some reason, my slides keep on moving, so I'm just going to make sure that this is taken care of before I actually uh, do this. Just 1 second. Okay. All right, here we go. Let me share the slides one more time so that they don't start misbehaving again. Okay, hopefully everyone can see my slides. All right, so one basic issue with this whole picture is majority of patients who actually get monoclonal gammopathy of undetermined significance are not going to go on to develop active myeloma. And the smoldering myeloma classification was created. It's not a smoldering myeloma is not a disease. It's a continuum. Patients go from MGUS to smoldering because there is an increasing disease burden. The oncogenic change has already taken place. In the MGUS state, many of the clonal plasma cell populations that are surfacing as MGUS, they may not have had the oncogenic change with translocations or hyperdiploidy. They have not developed the genomic myeloma change. And there is, a very important paper from our group that just came out in October, which will change the way that we're thinking about this forever. So patients go from having genomic MGUS to genomic myeloma. They may not have enough disease burden or end organ damage to actually declare themselves as active myeloma. So this definition and criteria that you see on this slide, it's still relevant clinically today, but in the near future, it will change. This middle classification of smoldering will go away. This middle classification of smoldering is a statistical definition. Smoldering myeloma on its own is not a disease. Multiple myeloma is the disease. So, that's an important lesson I want to give for the future, but I think from the clinical standpoint, we stick with this for now. And then, multiple myeloma progress over time. So for the longest time, the only treatments we had for myeloma starting in the late 50s was corticosteroids. Then alkylator therapy with melphalan and cyclophosphamide had been utilized. It wasn't until the early 80s that people like, my mentor, who's Dr. Bart Barlogi, who is one of the godfathers in the field of myeloma therapeutics as well as diagnostics. He was the one of the first people to actually publish on the role of autologous stem cell transplantation with stem cell rescue in patients with relapsed myeloma. So the premise was, he had been a leukemia doctor, and in leukemia, treatments were more aggressive even in those days. And so the idea was that why if low dose melphalan works, why can't high dose melphalan with stem cell rescue work and improve outcomes for patients? But then, heralded the era of immunomodulatory drugs in the late 90s, again with the introduction of thalidomide and its analogs by Dr. Barlogi and colleagues. And then proteasome inhibitors came into play with the work that was done by Dr. Ken Anderson and Bob Orlowski in their respective labs. And then this ushered the era of monoclonal antibodies going into the 2010s. And now we have bispecifics, trispecifics, CAR-Ts, antibody drug conjugates, third generation immunomodulatory drugs called cell mods that are coming down the pike. So many other treatments that are, coming. And then, the relative survival of myeloma patients continues to get better and better. So if I was practicing today, And all I had was proteasome inhibitors, immunomodulatory drugs, use of autologous stem cell transplant, and even one drug maintenance, regardless of whether patients are transplant eligible or ineligible, um, with adequate supportive care for bone health, infection control. Even today, the standard risk newly diagnosed myeloma patients would expect to live around, 12, 13 years. High risk patients, 6 to 7 years. And this is even if, with the current available treatments in Pakistan, I think this is achievable. There is access to, I understand the financial, constraints in getting drugs available, but um, towards the end of my talk, I'll talk about this a little bit more. But even if all you had was proteasome inhibitors, immunomodulatory drugs, use of autologous stem cell transplantation, and then maintenance treatment, I think this is achievable. And then, we'll see what the monoclonal antibody therapy era will bring in the next few slides. Because, I've seen this in my lifetime of going from doublet treatments to triplet to quadruplet and seeing an amazing improvement in survival outcomes for my myeloma patients. And that timeline is a bit slower, but it's very achievable in Pakistan. The next thing I want to talk about is this concept of minimal or measurable residual disease. So we've known, from more than 20 years ago. Again, I'm going back to, my time as a trainee and then going as junior faculty at the University of Arkansas's Myeloma Institute. We knew that patients who had, if we were just looking at serum protein electrophoresis and serum free light chains to determine if patients are getting to VGPR, CR, stringent CR, etc., we would know that even in patients who are getting to stringent CR, we don't know that there might be cells in the background in the bone marrow aspirate, in sitting in other areas of the skeleton, even extramedullary presence of those cells, that they would be hiding and they would eventually come out and relapse. So we needed better measures of detecting that disease and understanding that disease biology. At the same time, we needed treatments who would get us to undetectable levels of MRD negativity, because that is what will get us to the cure. And so, my team is tasked with the following mission. We think that the best chance of curing myeloma is at diagnosis, and it's doable in under 10 years now. When we came up with this game plan, last year with some novel therapies and some translational endpoints, it was the year 2024. So we are already 1 year into this, more than 1 year into this, and I think we're getting close. And this is the first and most important piece. Where do we draw the line? Where do we need to intervene between that definition of smoldering myeloma to active myeloma? So on that end, again, I would like you to take a look at that JCO paper. It is a very important paper. Work is already underway to utilize AI modeling to combine myeloma genomics, microenvironment, and immune profiling to exactly figure out where that genomic MGUS to genomic myeloma uh, uh, transition takes place. Once we've identified that, even when patients have low disease burden, but they have genomic disease, we'd be able to intervene with all the effective treatments we have right now. Then the next important step is optimizing frontline strategies that give us the highest likelihood of achieving sustained MRD negativity. I think this is very important to the road to cures. And so with that end, we have to optimize induction treatment, consolidation. And when we say consolidation, I'm really talking about that chunk where we do transplant. Transplant is consolidation. It's not allogeneic transplant. There is nothing magical about taking autologous stem cells and giving them back to the patients. The heaviest lift is done by high dose melphalan. Yes, there might be some immune reconstitution afterwards, but I think it's the high dose melphalan that does the most bang for the buck there. And then for maintenance strategy as well, for patients who are almost to the MRD negativity, but not there yet. Maintenance strategies can actually improve that sustained MRD negativity for patients. And this way we can define the duration of treatment for patients. So what our team thinks is that, we need 2 years of sustained MRD negativity at that deep level of 10 to the minus 6, so 1 in million cells or less than 1 in million cells. And then, having functional imaging, which would be, either a diffusion-weighted MRI or PET-CT scan. The imaging needs to be negative of any activity of myeloma. For high-risk disease, I think it's going to be important that, we at least look at 3 years because, there are some therapies that we are still developing in myeloma that or strategies that will get us there. But, that's still at least 8, 9 years away. And I do feel that we can increase the cure fraction in our patients without compromising on safety and quality of life. And how do we define that cure fraction? Sustained MRD negativity, again, utilizing the 10 to the minus 6 threshold, functional imaging, patients being off of treatment for at least 5 years. So, we can do the math together. Someone diagnosed at 65 gets, their life expectancy is 72, 73. Here in the US, in Pakistan, it's probably going to be, a little bit lower and also dependent on, longevity that exists in the family. But you can do the math yourself. If someone has been on treatment for about 3.5 years, they're off of treatment for 5 years, and they're still in a remission, the data that we have shows us that patients can actually stay in that remission for quite some time. And I do feel that this goal in the future will be achievable regardless of fitness level. We just need the right recipe to balance that benefit versus risk. So I've talked about high risk. What is high risk disease? We've had the ISS staging system, revised ISS staging system. I think moving forward, we are, given the fact that we have quadruplet induction treatments that have come into play, and then 1 to 2 drug maintenance treatments that have come into play. I'll share with you how many patients are getting to that MRD negativity status. So the original ISS staging, Salmon staging, revised to ISS, all included more disease burden related features, and some eventually, the revised to ISS included some genomic features, but these effective induction treatments are going to be an equalizer for disease burden. And now we can pay more attention to disease biology, and this is where this definition comes from. And that last point of high beta-2 microglobulin with normal creatinine is reflective of more proliferative myeloma. This, along with sometimes elevated LDH, can be seen in patients who have more proliferative myeloma presenting with extramedullary disease kind of features. So we're utilizing this high-risk genomic definition to actually do clinical trials in this subset of patients. And why is this important? I think it's the genomics that really drives the outcomes of patients. Even in a given patient, many different clones exist. And when these clones exist and we are only using sequential treatment, we keep on selecting out the more aggressive clone. And this is why identifying the disease biology at baseline and trying to utilize treatments that can effectively control and eradicate that particular clone is going to be important. And so combination chemotherapy is needed for that optimal disease control. And then the other important part is different clones may emerge at different bone and extramedullary disease sites. So getting a better picture of that disease biology is going to be important. We're looking at peripheral blood, cell-free DNA, so circulating tumor cells to, look at that disease biology. And then from a disease biology standpoint, the other very important thing that I want to share with you is when the genomic changes that are the initiating events in myeloma are translocations or hyperdiploidy. So patients will either have translocations or hyperdiploidy. And if you're not capturing that on fish or cytogenetics, there's something wrong with the test because that's something that myeloma starts off with. And then with subsequent treatments and as part of natural history of disease, you can have secondary and terminal hits that actually lead to more undifferentiated kind of presentations such as extramedullary disease and plasma cell leukemia. Plasma cell leukemia on its own is not a separate disease, it's a subset of multiple myeloma. So is extramedullary disease. It is a subset of multiple myeloma. It's that, you have secondary and tertiary events and terminal events that actually have led to that disease biology and those cells becoming undifferentiated. So that's a very important learning point. Okay, so let's see what are when we look at quadruplet anti-CD38 monoclonal antibody-based quadruplet induction treatments in a transplant eligible patient population, what is the MRD negativity rate that we get? So between induction, with induction, 20 to 27% of the patients, so 1 in 5 patients will get it. If we give high-dose melphalan, between 3 to 5 patients will eventually get there. And if we do a continuous therapy maintenance with 2 drugs, let's not, and I'm not factoring in cost, I'm talking about the science part here. 2/3 of the myeloma patients will get to MRD negativity at 10 to the minus 6. If we look at how many patients actually sustain MRD negativity, it's about 47% of the patients who sustain it beyond 12 months. And we'll have more data, in the coming years to look at the 24-month mark, 36-month mark, etc. That is quite impressive. This is not what I had, this kind of data, I didn't think that I'll see in my career as a myeloma researcher. Then for the older myeloma patients who are getting the quadruplet induction followed by 2-drug maintenance, 10 to the minus 6 MRD negativity is achieved in about 46% of the patients. But only about a third of the patients overall sustain MRD negativity beyond 12 months. So this is a good baseline. This means that we are starting to benefit a significant proportion of myeloma patients to this goal of sustained MRD negativity. And the story, for the transplant eligible patients started with a simple randomized phase 2 trial called the Griffin study that had been conducted by Pete Voorhees, and led by my previous center, Levine Cancer Institute. I was down there for almost 9 years to build that program. And this is one of the trials that was done. The concept was, let's just look at whether we can improve depth of response in patients by adding an anti-CD38 monoclonal antibody to that schema of induction, transplant, consolidation, maintenance treatment. And it was clear that we are getting patients to higher MRD negativity rates, and that starts translating into PFS benefit. As early as 2 years, you start seeing the separation of the curve. But the other remarkable thing in this study was what you see on the right side. The overall survival rates, even at 3 and 4 years, were about 92 to 93% in both arms of the study. That is, unbelievable. I was used to looking at OS curves that start touching, as soon as you cross the 5-year mark, they're already, down to 20% and so, back from the 2000s to 2010s to now, it was really remarkable to see this. So this Griffin trial informed the Perseus study. So the Griffin trial was a randomized phase 2 with primary endpoint of post-consolidation complete response rate. The Perseus study was a very similar design but powered for progression-free survival and conducted by our European colleagues. And I want you to pay attention to this median age of 61 years for the DVRD arm and for the VRD 59. So this is a younger myeloma patient population compared to the stated age that we have noted in my previous slide. So the punchline from this study was PFS very similar to the Griffin curves, 84 versus 68%. So the percentage here is a little different, 87 versus 70, but very similar PFS that you're seeing. And the OS is the same, over 90% OS at 4 years. And I'm going to show you towards the end of my presentation what that projected PFS may look like for patients. And this was at the median follow-up of about 4 years. We look at MRD negativity in standard versus high-risk patients. And even in high-risk patients, you have better MRD negativity with the quadruplet approach, and sustained MRD negativity is also better for the high-risk patients. So, it's not as good as for standard risk, but certainly better than the triplet followed by a single maintenance strategy for patients. Then, in parallel, there was another effort going on by the Italian myeloma group, where Francesca Guy was looking at utilizing carfilzomib as part of induction treatment. And the first question that she asked in the Forte trial was, well, do we really need transplant? And this question has been asked many, many times in the field, and we keep on getting the same answer about the depth of response, quality of response, and the PFS benefit that we get. But she looked at carfilzomib Lendex as induction, or carfilzomib cyclophosphamide as induction, along with stem cell transplant, followed by consolidation with the same regimen before patients get randomized to either KR or LEN as maintenance. And then one arm of the study was just KRD for 12 cycles before that maintenance randomization. The primary endpoint here was again depth of response, which came out superior in the KRD with transplant arm. So it wasn't just the depth of response in terms of MRD negativity, but you can see the sustained MRD negativity was better in the KRD transplant, KRD consolidation arm of the study. And if we look at the high risk and the double hit high risk, or patients who had two or more high risk karyotypic abnormalities, the benefit was quite profound compared to the standard arms. And these were some of the best PFS rates that we had seen for the high risk subset. And the Forte trial actually enriched almost 45 odd percent of the patients with high risk features. So the second important, part of this high-risk story is, well, if carfilzomib is a good proteasome inhibitor and giving nice MRD negativity rates and sustaining it, what about adding carfilzomib to it and seeing if we get better bang for the buck? Well, we did this comparison between the Griffin trial and the master study that had looked at DARA KRD as induction to see if there are differences in achieving complete responses based on high-risk karyotypic abnormalities. And on the surface, you can see that not much difference in terms of achieving CR or better. But when you start looking at MRD negativity, you start seeing the difference there. So, in our program, we for high-risk patients who have high-risk karyotypic abnormalities, we preferentially use carfilzomib based on the best available evidence. We do not have randomized trials or, many random. In fact, that there is only one randomized trial that has ever been done in high-risk disease, and that was the SWOG 1211 study that I had led. It was published a few years ago. But we really haven't had a lot of high-risk randomized trials. We are changing that. We are going to have more high-risk trials, but this is the best data that we get. And this data gets validated with isatuximab as well. So isatuximab is the other anti-C38 monoclonal antibody. So again, Francesca Guy looked at the winner arm of the for the Forte trial and added isatuximab as the experimental arm. And here the post consolidation MRD negativity rate was the primary endpoint. And this trial too had enrichment of high-risk karyotypic abnormality in about 40 odd percent of the patients. And the answer that we got was yes, MRD negativity is much better in the quadruplet induction arm of the study. But look at the bottom table on the right. Look at the 10 to the minus 6 MRD negativity rates for patients who have one or two or more high-risk karyotypic abnormalities. The MRD negativity rate that we achieve with the quadruplet here is much better than the triplet. So again, speaking to this whole concept that quadruplets are important, maybe we can utilize carfilzomib as the preferred proteasome inhibitor, and this is our typical approach here in MSK. We do prefer doublet maintenance treatment for our high-risk patients. Patients who are achieving MRD negativity after transplant and their standard risk, we're comfortable using single agent maintenance for those patients. If they're still MRD positive, we can use two-drug maintenance for those patients as well. And then let's talk about the transplant ineligible patients for a little bit. So patients, if they're frail, they're getting an anti-CD38 triplet. We can certainly talk about the merits in Pakistan of utilizing RVD light for those patients, followed by maintenance, or even doublet treatment approaches for those patients. I think frail elderly, the goals of care are a little different. And then for fit and intermediate fit patients, I would say that now, my slide is a little dated. So we have both ICE-RVD and DAR-RVD for this patient population. And we can use this as dose modified for induction, followed by maintenance treatment based on depth of response. The IMROS trial was the first to report in this transplant ineligible patient population, looking at isatuximab with RVD, followed by isatuximab Lendex as maintenance, with primary endpoint being PFS, which was superior in the quadruplet arm of the study here. And this also came from the fact that patients were MRD negative at a higher rate using the NGS method, in um, um, in this patient population. And then the OS, will take a while to report out, and I'll share with you the projections of PFS, at least in the Cepheus trial, to kind of, get that point across why PFS is the most important or the most appropriate endpoint to look at for newly diagnosed multiple myeloma patients. So the Cepheus clinical trial was designed with overall MRD negativity rates in mind. The standard of care arm in this transplant ineligible or deferred population was VRD induction followed by RD. And then subcutaneous data was added to both induction and maintenance portions or segments of the treatment here in the schema. The important secondary endpoints were PFS, sustained MRD negativity, CRO beta rate, as well as overall survival. So the study met its primary endpoint, and it was powered for PFS, as the secondary endpoint as well. So overall MRD negativity was almost twice as better in terms of odds ratio for 10 to the minus 5, 10 to the minus 6, and then sustained MRD negativity too was in the similar ballpark. And that translated into PFS benefits similar to what we have seen in the IMROS trial. At the 54-month PFS mark, 68 versus 49.5%. And this translated into PFS benefit, and this was eventually published. Now, looking at both the Perseus and Cepheus trials together, because these are quad induction treatments in different patient populations, the median PFS still not reached after significant, almost 18 months of follow-up. But you can see these curves, they're not hitting, they're not going to be hitting the 50% mark for a while. And some of the ways in which we look at PFS projections, the regulatory authorities, have the projections for, what's the maximum exponential or minimum exponential. And the best estimated PFS for transplant eligible patients right now is around 17 years with Perseus kind of an approach. And with Cepheus, it's around 8 years. Even if the projections are wrong, even if with Perseus we get a PFS of 12 years or 11 years, that is such a huge win for a patient who's getting diagnosed, say they're transplant eligible, they get diagnosed at the age of 60, and this first line treatment takes them all the way, keeps them in remission for 10, 12 years. That's a win. For the older patient population with the Cepheus population, I think that is more closer to the real world. So if I have someone who's 72 or 73, they get treated with an IMROS or Cepheus kind of an approach. And if it's not 8.3 years, if I get 7 years, if I get 7 years of PFS, that patient is going to be 79 or 80 by the time their disease is coming back. If I'm diagnosing both of these patients today, year 2025, 1st of November 2025, and I'm talking about 12 years, we're talking about 2037 for the transplant eligible patient. For the transplant ineligible patient, we're talking about 2032, 2033. The landscape will have changed. We would have had a lot more treatment options, that are safer, maybe in cellular therapy and bispecific, trispecific, whatever, coming down the pipe. So there are going to be so many other options that we can give to those patients, if we just kick this relapse scan down the pike for our patients. So, I won't, again, I'm trying to give like realistic, expectations, here. I don't think that it will be 17 years or 8.3 years, but even if, you apply, a desi discount, 20-25% discount, I think it's still a big win for those, patient populations. All right, so the work ahead. Understanding the timeline to achieving and sustaining MRD negativity by disease biology. There are different disease subsets, that actually have different trajectory to response. A good example is translocation 1114. That disease subset takes a while to get into a response. It's not a quick drop in M spike or light chains for that disease. So when these patients achieve and sustain MRD negativity is going to be different. So we have to optimize those induction treatment strategies according to disease biologies. And this is where I think BCL2 inhibitors and other strategies can be added. Same is true for translocation 414. It's a very quick drop in terms of response, but we know that those patients can bounce back up. So there are some other small molecules that we're trying to develop. What about the consolidation strategies? We're bringing in CARs, bispecific combinations, and sequential use of CARs and bispecifics or trispecifics for high risk. And it will be a defined duration treatment, kind of strategy to get patients to that sustained MRD negativity. And that work is happening. The MIDAS clinical trial was reported on at the IMS meeting last year. It got published in the New England Journal of Medicine recently. And this was a unique design. So this study actually had ISA KRD as part of induction treatment, but based on MRD negativity, again, they looked at the 10 to the minus 5 threshold, which I think is not the right threshold, but it is a good experiment to start with. Needs to be 10 to the minus 6. But then based on whether patients are MRD positive or negative, there was subsequent escalation of treatment for patients in MRD positive patients. And then, the lesson here was that MRD negativity post-induction, just as I had shown you in the previous slide, and this is 10 to the minus 5, not 10 to the minus 6. You can apply a 50% discount to these numbers, in fact, more than 50% discount, to the 10 to the minus 6 numbers. But not every patient is getting to that MRD negativity, but high-risk patients, you can see, are able to get to the same level of MRD negativity here. The more important part here is the point I was making about disease biology, that for certain disease biologies, it takes time, like, 11, 14 patient, it takes time to get to MRD negativity. And some of the patients, like translocation 14, 16, we still don't have a good answer for that patient population. That's, the MAF A, MAF B disease biology. We still need newer drugs for those patients. How are we going to do a better job in prognosticating risk in multiple myeloma? We are going to be utilizing AI modeling. If we start looking at relative risk and looking at these patients just by looking at disease burden and maybe few biologic factors, it's not useful for developing patient-specific tailored therapy designs. So, there is no genomic information here. So this is a big effort that we did along with, several colleagues around the world and in the United States, where we used genomic data, clinical outcomes data, look at, and patients who were comprehensively annotated to define or create this IRMA or individualized risk model for multiple myeloma. So right now, our group is working on IRMA 2.0. This initial data set was just based on doublets and triplets, and we have more genomic and immune profiling data that we are going to be incorporating in that version too. But that's coming. So what about future directions? I want to spend a few slides and talk about where the field is going. Um, um, I think cellular therapy technology is improving in leaps and bounds. There are point of care cars, in vivo cars, allo cars that are currently in development. A lot of that innovation is actually coming from China. We have very active labs in the US. Certainly, MSK has been a leader in cellular therapy approaches, and we are working on these ideas as well. But I think this will revolutionize the cellular therapy strategies for many diseases, outside of heme malignancies, actually. So, that's coming. And we'd be able to predict and manage both short and long-term side effects effectively. And that work also is ongoing in terms of creating several different models, prediction models. T cell redirection. So bispecific, trispecific technology is going to get better. Multi-agent targeting is already being developed. In fact, it's in the clinic. But a lot of engineering is being done with that technology to add co-stimulatory domains, have conditional activation where you can have an on and off switch to avoid on target off tumor side effects in patients. And then there are small molecules for disease subsets for 14, 14, 11, 14. We do not have anything for 14, 16, or 14, 20. So this is the MAF-MAFB disease subset, but there are epigenetic modulators being developed, on that end as well. Um, what about quality of life? I think a big focus is to define duration of treatment based on sustained MRD negativity. Um, Frailty assessments are being added in routine care here at major myeloma centers. I think these tools can be incorporated into electronic medical record systems to give a real-time assessment for patients, and we can modify our treatments. Hamza Hashmi from our group at MSK is working in this particular area. Supportive care measures would get better. Primary and secondary prophylaxis for infections is getting better. And then minimizing that risk of second primary malignancies is something that we are all concerned about with the current as well as the more emerging therapies that we have. I don't think we can eliminate that possibility because these are older patients. They're always going to have other competing health risks, including other cancers. I'll share another interesting fact. Given the fact that at Memorial Sloan Kettering Cancer Center, we see patients from many different parts of the world, as well as, from the United States. Um, for many patients, I think in 1 to 2 out of 20 patients, myeloma is actually that patient's second cancer, sometimes the third cancer, because myeloma tends to happen in later in age. So these patients may have had a lymphoma or breast cancer or a GI malignancy in the past. And myeloma is actually their second cancer. So, the risk, that we're looking for after someone develops myeloma is actually a third primary malignancy, not a second primary malignancy. So, we have to keep things in context when we talk about that particular risk. I think this is where going to be very important, improving global access. And this is, very dear to my heart when I think about, our patients in Pakistan. We need good support from local, regional, academic, and regulatory leadership to actually improve access to drugs. Um, Oncologics are not manufactured in Pakistan. Our neighboring country manufactures many of these drugs at a very low cost for their population. They're now even creating CAR T cell therapies in their country at a very low cost. I think if we're going to improve, and I do believe that we have the technology wherewithal to create these treatments at a very low cost, in our in Pakistan. But it is going to require local stakeholders to really, have um, um, have a say in this. It will also require patient advocacy, which is very strong here in the US. It's strong in the European countries, and it would be very important to develop that kind of advocacy in Pakistan. Industry support is always going to be important. Professional societies can liaise with each other, local, regional, as well as international. On this end, for myeloma in particular, International Myeloma Society is doing a lot of work, and there is an opportunity to partner with the International Myeloma Society by different countries. We have good engagement with the FDA, with the EMA, and there is no reason why we can't do something similar in Pakistan if there is interest. My predictions for the future, and I should actually write 2035 and beyond on this slide. But most myeloma patients will only need first and second line of treatment, and that will be enough to get them to a functional cure. They'd be able to live 20 plus years, with myeloma, and then again competing health risk or something else might come along, to affect their health. We have the drugs to do this. For standard risk patients, for sure. For high risk patients, we're getting there. I think predicting relapse will become more accurate using AI modeling in the future. And the attrition rates with each line of treatment will decline over time. And that is what will lead us to that functional cure for our patients. And then treatment initiation at MRD resurgence. So we have always looked at MRD by doing a bone marrow aspirate, looking at flow cytometry, and more recently, next generation sequencing. But I think in the future, we would be able to use peripheral blood assays. And again, these are very doable in Pakistan as well, utilizing mass spectrometry, circulating tumor cells, or cell-free DNA technologies are in development. And then functional imaging, this technology will become cheaper and cheaper with PET CTs and DWIBS MRIs. So I think utilizing these to look at MRD resurgence and reacting to it to control disease is something that we are going to be looking at on the research end, and proving the point that we may be able to utilize them to initiate treatment early in patients and eradicate disease clones. This is something that's done for other malignancies as well, and can be done for myeloma. And in the end, I would like to give a big shout out to my whole crew here at Memorial Sloan Kettering Cancer Center, all our collaborating labs and our funding sources. And I would be happy to take questions from all of you. Thank you so much for the opportunity.
Pakistan can benefit from this greatly. Of course, we are recording it and we'll share it. I will not be able to feed the questions section here because it's difficult to read on cell phone screen. But if you see, there are, I think, in the chat messages, some 8 messages are there. Thank you.
No, I can address them, Faiz bhai, if okay. Okay. All right. So one question I have is how successful you believe AI will be in prognosis and treatment of multiple myeloma? So, my answer to this question is AI is dependent on us to ask the question, to input the data and create the model. So it's AI on its own won't do anything. It is how we utilize AI to do the coding and ask the particular questions. So I think this is going to be very important. Um, you still need the human mind to ask those questions. So it's really generative AI that will help with the prognosis and treatment. And there is a JCO paper from in Journal of Clinical Oncology paper from last year that was published. Francesco Mora is the first author. And that was our first attempt to utilize this model. You can input the data in a very similar fashion from patients in Pakistan. You just need to create those comprehensive data sets and have that prognosis prognostic model developed. I do feel um, that whatever modeling we do, it has to be patient population specific. So this kind of project can be done in Pakistan. I'm happy to liaise with others. I know there are, Dr. Rahil in Rawalpindi, and Dr. Zeba and others are interested. Dr. Musa ji and Burhani at AKU, that they're interested in doing something like this. So it's something maybe we can do as a pilot project. And the second question was, do we have any CAR-T centers in Pakistan? Right now, we don't, but hopefully in the future, we would be able to do that. I know we've had discussions. Some of us have had discussions with the colleagues that I mentioned about bringing this technology to the transplant cellular therapy centers in Pakistan. Dr. Umair Mushtaq, who's one of our rising stars, is trying to lead this global effort in bringing LMIC countries these technologies, not just the education, but also the technology transfer. So I think that would be great. Um, so I have a lot of comments, other comments here, in addition to the questions. Thank you for appreciating this talk. I do have this comment from Dr. Suhail Amin. It's too detailed and thick presentation. Please make it general audience friendly. That's not my job. You can have a lot of friendly talks and simple talks, but I had stated at the beginning of my talk that this is going to be very forward thinking. I'm from I'm from Pakistan, and I'm able to do a lot of these things here in the US. No one taught me to do this. So the message I'm trying to bring is that these things can be done by us in Pakistan. We just need to be able to, do them. I do feel that we can do them for many different diseases. That was the whole point of the talk, that मैं आपके जैसा ही हूँ. And this is all doable.
And I completely second that. I completely support that. This is a world-class lecture. I don't think you can get to this kind of a better lecture than this lecture. So if we here in the USA are able to comprehend this kind of a lecture, our vision is that people in Pakistan should also be able to go to that level and comprehend this kind of a lecture. Thank you. And on the similar note, Dr. Umair Mushtaq actually is hosting currently a trainee in his center to go for further training for clinical CAR-T care. So a lot of credit to Dr. Umair Mushtaq and all the colleagues who are involved in that initiative. Thank you.
All right. And then if there are no other questions, Faiz Bhai, we can even close this a little early. And uh, truly appreciate all of you joining this morning session. And I think we'll be back next weekend again. Thank you.
Thank you. Goodbye.